Welcome, guys, to another episode of the Pharm So Hard Podcast. This is going to be a live episode. It's going to be something completely different than we've ever done before. Super excited to have probably the smartest nurse I've ever met in my entire life to come talk with us about a variety of things that may not necessarily be pharmacy related, but if you're smart, you can learn something and it can help you become a better pharmacist, nurse, and physician. I'm going to go ahead and welcome Brian Cox to the episode. It's going to be a phenomenal series. Any other credentials and things like that you want to mention that you have? 'Cause I know you have alphabet soup behind your name.
Well, I do. I don't think I'm the smartest nurse there. I found it's best to learn. I have my bachelor's degree from the University of Delaware. My wife and I both went there. That's where we met. And I actually have a degree in biology. I actually was going to go to med school, is what I wanted to do a long time ago. Then I became a paramedic, and I worked pre-hospitally for a long time. I started that actually in '92 when I was in high school, which was pretty cool. Yeah. And then worked EMS for a long time, and then I went back to nursing school. Okay. When I graduated in 2004, I really wanted to do peds, so I did that for 4 years, and then realized I really wanted to go back and do emergency medicine. What I knew, which I liked. And
the best specialty you can possibly have.
I think so. I think you can't get a more rounded, more diverse one group of people, but also patient population and what you're going to do. Anywhere from critical care to hangnails to fractures, literally you do everything.
Yeah. Is there something that you can come in and people say, oh, I'm tired of my job, I'm doing the same thing over and over. For the most part, you would never have to say that in the emergency department. So unless you're like, oh, I have traumas, then you start thinking about the type of traumas. You just get jaded probably. Mm-hmm. But for the most part, you get to see everything.
Yeah, and it's hard to say that, but we did do a crack in the CT scanner a few months ago, and I was like, I think I've seen it all. I could be safe. But then again, you never know. You really never know, and that's what I like about it.
And my thing is like, what the great thing about emergency medicine is that no matter where you work after, you can apply the same skills that you get from emergency medicine, apply it to the ICU, you can apply it to PEDS, you can apply it to all these different areas because emergency medicine is a specialty of specialties.
Mm-hmm. So yeah, and I definitely agree with that. It's a specialty of specialties, and you know a little bit of everything.
Yeah, it just makes it go well. Mm-hmm. So let's go ahead and jump into this. This episode is going to be like a hodgepodge of different ideas, and I want to title it like things we do in the ER that may not necessarily be the smartest. So I didn't want to say dumb things we do.
Dumb things, yeah. We do a lot of dumb things. I think sometimes, inefficiencies, or maybe things that we don't work on that we should work on, that we're not good at, that we should be good at.
Yeah, so this episode we probably talk about how to get better. Do better.
Absolutely, how to do better.
Do better is what we're going to talk
about. Should do.
So the first thing that we want to talk about really is like EKG interpretation, because it's something that usually the EKG is ran by you guys, depending on what shop you're going to have, and just immediately handed over to the physician. If they're right beside you, then a decision is made, and you're just waiting for that information. So can you talk about like different aspects of EKG interpretations and different things to look for and how it can make you a better nurse, and pharmacists out there, how it can make us a better pharmacist as well?
No, absolutely, I agree with that. The biggest thing with from a nursing perspective, especially in our shop, is it's the importance, since if you're credentialed for STEMIs, and having those EKGs done out in your waiting room triage area, or however you have it set up, everyone's set up so differently. The biggest thing in our area is really just a recognition of it. And understanding first what's normal, PQRST, what's normal EKG looks like, and how to interpret what a normal EKG looks like. Unfortunately, a lot of our patients don't have normal EKGs, but you need to understand at least the baseline, what they're going to look like. And then I think the other thing is knowing irregular versus irregular. Is it fast? Is it slow? Is it going to be wide or is it going to be narrow? So when you're dealing with like fast, wide, or are you looking at VTAC? Or if it's narrow, are you looking at SVT? Or if it's irregular and narrow, are you looking at AFib? Where it kind of gets a little tricky. So you need to determine those. And then I would say the biggest thing sometimes is those left bundle branch variances, which seem to get a lot of people. And you can dig really deep in all these and go down a lot of rabbit holes.
Especially like you have one previously in the past. Is it new? You know, is the patient new to your facility and you can't go over that? So it really makes it challenging.
We've had those in the past too. New left bundle branch, what is it? And I think that's where it just becomes important, if you see a left bundle branch, knowing what it is, getting it in front of the physician right away, because we need to make it. There's so many criteria you can use to determine whether that's going to be a STEMI.
And the question I always have is like, usually we call a stimulant, say we call one of these things, and then the cardiology teams come down and they don't agree that it should be. Like, how do you advocate for your patient in those scenarios based off knowing a little bit more about EKG and more than the patient than the quick, 2-second glance and like, we're done?
It's difficult. Just where we work in a teaching hospital. There's lots of people, there's lots of layers. And we have a process. So our biggest process, so if it's pre-hospital, we get the EKG ahead of time. Now, a lot of times they're going to go on what the Zoll monitor tells them, or whatever monitor they're telling them. It's got a protocol already embedded in it, a mathematical protocol that's going to tell you whether it's a STEMI. That's going to happen. That's fine. I think that's default. Just be default aggressive on that. We have to at least get that EKG in front of the attending and then decide if we're going to call it or not.
Okay.
The biggest thing when it comes to waiting room and triage is one, recognition. Do you understand what the STEMI looks like? And I'm not taking the very small indicative ones, but if it comes across on the EKG as saying MI and you're not sure, put it in front of somebody. But understanding what ST elevation is, what it looks like, and what like the classic STEMI. Now, when it comes to having cardiology involved, we, is what I find, is default to the experts a lot because that's their specialty. That's their job. However, doing this for a long time, I think emergency medicine and emergency physicians and some nurses that I know that are really good to get into this, and even some paramedics, because I know some paramedics are good at this. I think they can make those decisions. I think they can call it. The way the system is set up, I think we have to defer to cardiology and what they are going to determine what's a STEMI, where we're going, and what's going to be the plan after that.
So one thing is like, what's some resources people can use, or some things you've used to help yourself become better at recognizing EKGs? You've been doing this for a second, so you've been able to see off experience. But like, what are some tools you can use? Because you listen to all type of podcasts. You can use your phone,
so there's a lot of podcasts. There's, I can't remember the guy's name, out of Hennepin County that does a lot of EKGs. The biggest thing I would say is one, ACLS has a lot of good stuff.
True.
Then there's a lot of books out there. I think there's a lot of books on EKGs that you can read and get experience from. And then the other thing is podcasts.
Yeah.
Listen to podcasts, look at podcasts. A lot of podcasts will have notes and they'll be able to show you EKGs, examples of STEMIs. And then there's a lot of online resources.
I think Life in the Fast Lane.
That is a really good one.
Like thing for that. And then have you been associated with like the Orange Book? Like it's like a EKG book that.
No, I don't know that one.
It's like actually a textbook, I would say, that goes through those and like try to help you do it. But everyone has their resource when it comes to EKGs.
But I think Life in the Fast Lane's really good, and people don't realize that's Australian, but it's really good. I thought some of the guys are not in, but my thing is like with globalization and so much foam out there. Yeah. There's a lot to learn from a lot of people from other countries, and they are, some of them I think are just as smart, if not way smarter than the people we have.
And it's just like bringing everything together.
And the biggest thing is they bring so much together.
Yeah. And so I guess it's wrapping all the EKG part up is just like understanding what's normal. Like what your patient look like in front of you. If they're screaming like I have a STEMI, I'm diaphoretic, my chest hurts like crazy, this is new, I've never had this, it just started. I think pushing more like, hey, let's go ahead and get some of these things started, like the aspirin, plus or minus the heparin, and then some of the other agents we can use. And that's how recognizing EKG, recognizing your patient, and how that can help benefit the team and the patient.
And moving forward, because really, I mean, what's so hard for us is getting transport, getting these patients to the cath lab. And that's really the priority is recognition, getting that EKG in front of the physician, making the decision, and moving that patient. And
then like the caveat is like what matters. And I'm just gonna throw this out there for in this part about STEMIs, because depending on where you train, depending on who's the resident, for one, I've had people tell me they don't know how to put in the med orders.
Correct.
Cool. So your nurse is gonna have to learn how to do that and do a verbal, making sure there's adequate verbal readback so there's no miscommunication.
Correct. Especially when it comes to like heparin. A lot of times they'll want Brilinta, they want the atorvastatin, and they want aspirin up immediately. And it's picking and choosing your battles, or even the Plavix. Picking or choosing battles, what you can get here now quickly and getting that patient. Because really it's time. It's not necessarily always, to me, the medications. You can get push dose heparin real quick. You can get the aspirin, you can throw it in their mouth and chew it up. But make sure you timely get the patient to the cath lab, because that's going to make the biggest difference.
And don't delay. So pharmacists that's involved, whether you work in the ED or not, have these medications ready for your nurse to pull. Don't have 1,000 products, because you can have your heparin flushes that's there, three different concentrations of those. You can have your heparin that you have for your sub-Q for prophylaxis, and you can have all these different products, and it leads to errors. So
yeah, I've done it because you put like type heparin in our, and we have high dose, low dose for your flushes. We have sub-Q, and then we have IV push for PE and our cardiac protocols.
So we recently, it's like a virtual kit. So like you go in, patient, STEMI.
I think we still have the STEMI kits.
Yeah, so they just revamped it. So the STEMI kit, and you just pull all those, and like that's it. So that's an easy way for us to prevent errors and like make it easy to do, and make sure all the other ones are not on like auto verify or override, because I've never seen a stat sub-Q, heparin for DVT prophylaxis. Like it's just not.
And someone tried to do stat Berlinta the other day, and I was like, we don't. Where we're at, it's 2 ERs. It's like, well, there's 1 ER. We don't carry Berlinta because it's not something we give all the time.
Yeah. So it's like figuring out where these things are. Where these things are at, and some, the data for Berlinta versus Plavix may be showing that Berlinta is a little better agent, but I think we have to make it a system deal. If you want something fast, make sure the system makes it fast.
Correct.
Like I'm not running upstairs to get around.
And that's the thing. What happens is if it's not there, then my thing is like our priority needs to be getting the patient to the cath lab, or doing recognition and movement, not necessarily running to the pharmacy to for a 20-minute delay for no reason.
And it's just strange, because I think most physicians, most pharmacists don't realize the process of getting a STEMI patient from the ED, from the waiting room to a room to the stat, so like a stat cath.
It can take, even when you're doing good and you're working well, and I had one recently last year that we did a really good job. I thought we did a good job. It's still like 20, 30 minutes, and this was like 9 o'clock at night. And they're like, remember, the cath lab team has 30 minutes to get there. The transport crew was there right away. I was actually in triage. I looked at the EKG. I was like, man, it's going to be a STEMI. Went right to the attending, called the STEMI, got the patient in a room. We worked the patient up. I went with transport. I mean, even with everything working, it still took us almost 30 to 45 minutes. And it was nighttime. There's always delays because you have 30 minutes to get in. But even when you're doing it right, it could take you 20 minutes.
So I think everyone has this misconception that like, you see the EKG and they're immediately upstairs and they're getting cath, and
it just doesn't work that way.
That's great. Another thing I would talk about, simply talking STEMI right now, with the COVID era kind of being behind us a little bit, there was a time where people wasn't getting the cath lab with adequate EKGs, and there's different things you can do.
Correct.
If you're at a small shop and you're not going to take the patient to cath within those couple hours, realize that you have to start thinking about thrombolytics, and your nursing staff and everything has to be prepared for this.
Who wrote that article? Was that emergency medicine
cases?
Did ASEP put out a statement about that? How they noticed that their MIs and strokes were down last year in ERs, and I think that was a big deal. And I think people forgot, like, you have T and kinase you can do. And you have other things, and this was before we had the rapid. We have rapid testing now. I mean, everyone gets a test in 10 minutes or 2 hours. So this was before any of that was around, or what we knew about COVID now. And now, as long as you're vaccinated, even heck, if you got one shot, you're good. But as long as you're vaccinated now, there's like so many people that it's not as big of a problem. But it goes back to that, thinking about it. And I can tell you, it's time where I worked critical care transports for another system, and they did a lot of T and kinase because it was an hour ride to the cath lab. And you can give it before they go to the cath lab, because at least you're doing something for them.
And this is a weird thing, and some physician out there, some person smarter than me, tell me, I always hear, oh, you gave them thrombolytics, we can't take in the cath. So my recognition, I thought the first studies back in the 90s, the Gustos, although those patients went to cath lab and got thrombolytics. And we're better at cath lab and our minimally invasive procedures now than we were back in the 90s. So I hear this and I'm like, I'm
going to age myself. When I was doing, after college, I was doing transports for a hospital system, and I got to watch TPA pushed in the ER a few times for acute MIs, and they didn't go to the cath lab.
And that
really outdates myself, but
so
I remember we did that too.
Nurses, look for your dosing, because it's completely different from your PE, and it's like, you have a bolus that could be around 15 milligrams, and then you have a weight base for 60 minutes. For 30 minutes, you have another one for 60 minutes. And this is for people with a pulse. So just look it up. Pharmacists make a protocol. We've recently done that.
Okay,
we talk about, if you have a cardiac arrest, you can go this route. If you're breathing, you have everything you need, and it's going to be a delay. We have this weight basing you can do, but the pump has to be set up a certain way because it's 3 different setups.
Yeah,
so if your pump is a bolus, so
that I wouldn't remember.
So again, that stuff we just look up on Lexicon, figure it out. It's challenging, so I always just mention that as well.
Yeah, I didn't know that changed.
Yeah.
So, and that's the other thing, because I'm so used to just going to the campground.
Yeah.
Like, we just have access. But yeah, if you're working in we have very rural areas where we live, and the possibility for that could be very high.
Yeah.
Where you have a patient and the physician does make a decision to do TPA before they get sent to us.
Yeah. And especially think about with Connected Place being out there, it's a bolus. It makes it a lot easier. So personally, for me, I would want to go that route, knowing that 9 times out of 10, the syringe is 50 milligrams. At worst, if you just overdose them, they're going to get 50 milligrams compared to whatever the dose is going to be for an altar place. So
yeah, and that's 100 milligrams in a vial, and if you screw it, I mean, you could mess that dosing up really easily.
So that's
a problem.
Anything else from like an EKG interpretation and STEMI standpoint, because it's so much that go into that. I think most people don't realize.
I think it's understanding the basics.
Yeah.
Go through your ACS AHA guidelines. The cap, looking at the little 1 millimeter elevation here and there, and those things. I think you're going to dig into a rabbit hole as an RN, or even as a pharmacist. I think the biggest thing is recognizing what a STEMI looks like, ST elevation, usually in your lateral leads, knowing what reciprocation looks like, and knowing that you have a possible STEMI is the most important thing.
Yeah. And just gauging your level, because I don't want a pharmacist like, oh, yeah, they're sitting aspirin. Like, no, this is the important aspirin. If they don't have it down here, just look at your patient, understand the situation, and go from there.
Especially if you think about it, we've never got EKG. You don't get EKG training as an RN.
Yeah. And we get some, again, depending on what shop you train at, but it's just that. All right. Next thing, I think matters a significant amount for me. Most pharmacists probably don't think it matters. If you're a bedside pharmacist, as I like to call a lot of our ER pharmacists out there, if you're at the bedside, you need to have access to do these things or it gets tricky.
Absolutely.
IV skills, obtaining IVs is like, I can't get it. I need this, I need that. Talk about like IV skills and like ultrasound guided IVs, because it's a lot of talk out there about, for one, does your shop even allow you to do them?
And that comes down to the regulations set up by the nursing board. So the biggest thing I see is it's not a skill. And I don't like it. It's not a skill that's taught in nursing school.
Yeah.
The opportunity to do a lot of IVs, I just didn't think it was there when I was there.
Yeah.
I come from a different training background. I was a paramedic, and the way we learned was you shut the door in. You're not allowed to get out of the back of the truck until the IV started. Yeah. I'm not saying that's the best way to do it. I'm just saying that's how kind of we did it in the field sometimes, and that's how you learned, and that's why when it was 2 a.m. and car's upside down, you're in there, so you can start an IV because you learned. I think so on the nursing side. I think it's one of those skills that you almost feel like we've gotten away from, and yes, there's some literature out there that says like up to 25% of our patients don't need IVs. But what about blood work? What about phlebotomy? What if you don't have phlebotomists or techs that can draw blood? So this is where it comes down to, this is going to be practice makes perfect. You've got to try, and you've got to try, and you're going to fail a lot, and that's okay, but it's just a skill you're going to have to learn, and it's going to take time, a lot of time. I thought Rob on ERCast had a good, I'm going to have to look at it, I got it on my phone, but a good article. It was by Michael Whitting in Journal of Emergency Medicine, was predicting failure of IV access in adults and the value of prior difficulty. And basically, to summarize, they found after they had like 600 patients, and what would happen is the nurse would come to the doc, just kind of paraphrasing, and say, hey, this is a tough, difficult stick. The doc would be like, go find someone else to do it. Okay. Only 14% of those 600 roughly were really difficult sticks that needed ultrasound guidance, central lines, or something else. Okay. So I really think that it comes down to is, and there are policies and procedures in every hospital about 2 sticks and out, things like that. And yes, you do have to be aware of the patient. Yeah. I think you do have to listen to the patient, tell you what they're saying. But it was interesting, this study, if you read it, it almost is like even the difficult sticks, someone was able to get it.
Yeah. And especially you hear the patient say, oh no, get a butterfly, or oh, you got to do these different things.
I hear it all the time. I need a butterfly. It's like, I'll get a 22. We just need blood and a line, and I can make things happen.
Yeah. And then can you just talk about the difference for me is like the long versus the short ones, like the different gauges that you can place. I know people say, oh, I want like a 20 long, while I want just a regular. What does that matter? Like,
so it does for flow rate. If we think about it, we go back to flow rate in physics. The shorter the catheter, the faster the flow rate's going to be. The longer the catheter, it could be the slower. Now, when you're talking about ultrasound lines, and we're doing the ultrasound lines, which I think alternative IVs is a good place to just kind of start on this before we discuss. Like, alternative IVs are good. Like, ultrasound lines are very good. Now, length, I think, makes a huge difference on the ultrasound IVs. And this all depends on where you practice. Where I practice, we're allowed to do them. And I got a lot of experience doing them. And we have a lot more nurses learning how to do them. And it's a great, great supplement. It's a tool, though, in your toolbox. I don't think it's your definitive. You got to use just like everything else in life. It's part of your toolbox. But I think length makes a huge difference there, because basically if you're going for deeper veins that are smaller, you're going to need the length, because you're going to need the length to go through all that depth to get in. And if you think about it, they're at the tip of those needles are just 2 millimeters of needle. You have to have the needle in the vessel plus the catheter. So the longer that catheter is, if you think about it, it just base-wise going through all that tissue down to the vessel and then getting that catheter in. You want the length so you can have a good portion of the catheter in the vessel without whipping out on you.
Yeah, then it make it harder for it. Just like, I lost the line here, I lost this there.
So my thing is I always go for fat and very shallow vessels. I have more success with that. But you can even those, they're going to whip out, patients flailing around, you got a violent patient that's altered, they're going to come out too. And you got to make sure one's securing. And you can screw it up too. I thought I was in a vessel that was long, deep enough, big enough, and it just wasn't, and they whip out. And then the other thing, of course, is you have micropuncture kits that are out there now, which I really like those. A lot of the docs will do them at bedside. We're not allowed to do them as nurses. Some places you are allowed to use the micropuncture kits. And in my thing, and this causes controversy, but this has pretty much been, I think, should be quelled by now, is EJs are not central access. And having the opportunity to learn it, paramedics did it all the time. And when I worked EMS, if it was an issue, put an EJ in. You didn't worry about that. And we didn't have IO guns when I was in EMS. Not to when I got off the street. When I was getting off the street, we finally got the IO guns. But our thing was, like, you didn't get access, it was cardiac arrest, and put bilateral neck veins in. It's what you did.
And I see every time, it's like they come in, it's like, oh, we got pounded EJs, he can definitely do that. And I'm just like, I need to get fluids, I need to get blood, I need to do these things. Now, I don't care how you do it, but get it done. But I think we just run out of options.
We do, and then some of it is legal, and that's fine. It is practice. It all depends on your practice, where you're at, what you're allowed to do. I think going in the future, I don't see why nurses can't do a lot of those other procedures. As long as there's correct training, and you're trained the right way, and you use the adjuncts you have, ultrasound, things like that, and all the new techniques that are out there. There's tons of different IVs you can use, I think, to help make those procedures more beneficial and more successful. I think we can move to that, because I'm going to be honest with you, and I think most of ER docs, especially when I worked at a small place too that didn't only had physicians, there was no residents. They appreciated it more that the nurses could do these other procedures because it didn't bog them down. When you're in a 20-bed ER and you're the only physician covering, you don't have time to start IVs every hour. And this gives, I think, nurses the opportunity to, one, if you have a difficult stick, always use someone else that's got more experience or someone else that's really good at it. But you still got to try. Don't give up. That's a big thing. Don't give up when you can't try. But then when you truly have a difficult stick, having nurses the opportunity to have ultrasound, EJs, IOs, micropuncture kits, other techniques that they can use in order to be successful, so you can get IV access. Because before we were doing ultrasounds, even in our shop, the PAs would get stuck doing IVs all the time, which drug down, took them away from doing patient care, getting dispos. Now your dispo times are going up and things like that. And I think this is a lot of this could be given to nurses, one, to make them, I think, their practice feel a little more fulfilled, like they're getting more opportunities. And I think it would speed things up.
Even if nursing staff can be doing all of that, by the time the physician comes to get things done, it's one of the things that you probably don't appreciate until you not have access and need it to do something.
You need it,
So I think it'll help from a nursing staff from an autonomy standpoint, a PD throughput standpoint, even if it's not an ED, like it's just throughput. Like if you can get someone in general, it makes it so much better. So
and EMS providers, that's why they're using it. That's why they have IOs. That's why they have EJs. That's why they have King Airways. That's why they have LMA. They have all these adjuncts to help them do their job to get care started. And for us, it would be just, and I think for nurses, one, you got to learn how to do IVs. It's a very difficult skill. You can't get frustrated. You got to try. You're gonna get difficult sticks. That's okay. And a lot of times, just get the IV. Don't always worry about being the AT and then the AC, unless you're gonna need a procedure like certain scans. We can do it, but also talk with your CT people. You'd be surprised how much you can do with a 22 if you have a difficult stick and you want to just speed the process up. And then from there, once you've got that process done, I think it's having those alternatives are absolutely important. And I think it saves time from the physician.
Absolutely.
Because their job is to dispo. They need to see patients, write orders, dispo.
Yeah, and they're not super sick. Like, you just need to get what you need. And sometimes I believe, like, just understanding why you need to access is like, if I have a patient that's an ESI 5 that's coming in that just needs some labs, that's a different mindset versus if you need like a dang on,
And we don't do that a lot. There's a lot of patients we could butterfly, get labs, do PMEDs out the door, and speed the process up by hours.
Yeah. But I think having phlebotomy, that helps out sometimes. When I was at Grady, they had phlebotomy in the ER.
See, that's awesome.
Every shop doesn't have that, so I feel like everyone has different resources. But again, the only thing that ER will have is a nurse.
And that's majority of and if you look across the country, the majority of the ERs are not teaching hospitals.
Yeah.
They don't have tons of residents. They are managed by private practice, and then not private practice, but they're managed by emerging medicine physicians.
Yeah.
And a lot of times it's 20, 40 bed, could be 60 bed ERs that have physicians, PAs, but if they're covering 10 patients, they don't, that's taking time away from dispos and things like that need to be done.
All right, so IV skills is out, and the next part is like where I feel like it's definitely interesting. Meds that we just don't need. I talked about a few of this before, but you got a GI bleed person comes in, and they have some vomiting. It's horrible. First, it stinks. Like, that's the first part that makes it bad. Like, everyone who's like practicing the ER or
knows what GI bleed is.
Yeah, you just smell it. Like, I remember I walked in, I feel like my proud moment in the ER. I just clocked in, I was like, there must be a GI bleed in room 8. Didn't see the patient, wasn't close to the room, but I was able to figure it out. And, oh yeah, it actually is. It's a horrible smell. Then we go to the fact that people get so aggressive when it comes to treating them from a medication standpoint.
Correct.
And you want to be a superhero, and I want Triotide drip, Protonix drip. If you got Nexium, it's your shot. Nexium drip. All these things, and like when you go to the bedside, you realize they don't play nice with each other from a compatibility standpoint. They top your line for a long time, and usually these people don't have great IV access from begin with. So you're happy just to get your 1 or 2, and they're saying they want fluids going, they want blood going, and they want Protonix going, Triotide going. If these patients get any sicker, requiring like Levophed or any other pressor, it becomes horrible to deal with.
Absolutely, to manage all those meds is the biggest thing.
But the data just doesn't.
There's been good podcasts about this. I know we've had this conversation. Our other pharmacists have, and like Triotide and Protonix and Nexium, they should never be ordered anymore, as far as I'm concerned. That is evidence, I think, that's there that says why. It's just tying up lines. It's more, you can give Protonix IV PO. I can't remember the dose, but it's twice a day IV. And you can give them blood, and you got 2 lines. You don't tie up 3 lines. You're not, the patient's not tied down with all this stuff, and it saves money, saves time, saves effort, and there's no evidence to really support it.
Especially, again, the drips are the crux, because like anybody can mix up a 40 or 80 Protonix and give it as a bolus. That takes no time. Anyone can give that 50 to 100 mic Triotide. That's no problem. In the ER, like, we're not there to like do, like, that first dose is going to work for like hours. Like,
cover you.
Like, these things work for 12 to 24 hours. Why are we doing it? Again, we do it because the dogma say do it, but it is insane.
It is. It's just it's frustrating to see, and then we have to order it, and then this has happened to me. A newer like AOD will come down. Again, we don't need all that stuff. I'm like, thank God.
And that's the best case scenario. What I think is interesting, when you have some junior, practitioners and junior nursing staff,
new grads, because that's new grads coming out July 1.
So everyone's like, oh my God, this is so important. And then what happens is this: you have to make it in pharmacy. they make it a stat, they send it down, the patient somewhere else.
It could take 30 minutes to make it, depending how busy they are.
So by the time you patient get that med, for one, I've counted every day I come in now, there's a Protonics and an octreotide drip sitting in the return bin.
That's my thing. It's a waste. And the biggest thing is, one, it's a waste of money.
Yeah.
And I know I run a business now, and I'm learning this the hard way. But just in healthcare, it's like we can't waste money.
Yeah.
Money doesn't grow on trees. Healthcare is costing more and more. Just in a plain sense of numbers, we're wasting money.
Yeah.
Like that, we're not going to get back from the insurance companies.
Yeah.
Medicare, Medicaid, CMS, they're not going to pay for all this stuff.
Yeah.
Especially if we keep wasting it.
And consistent from a pharmacy standpoint, our budget's always in the red.
Exactly.
It's like,
So
how
why
can we
waste more
find
money?
time? So ER pharmacists everywhere, get your shop changed over or have it set to this. I'm going to give the bolus in the ER. If the patient's sick enough to require a drip, they're going to be sick enough to require quick dispo. Once they get themselves to the unit, get themselves to a step down wherever they're going, they can start that there.
Correct.
Because clot stabilization, decreasing pH, that happens with the bolus. All this stuff happens with the bolus and you maintain it. But again, depending on what shop you're going to, I've been places where we get people upstairs within a couple of hours of actually talking to the admitting team. There's no need unless that patient's hanging out in your ER for a day.
No.
To add some of these drips. And some people even talk about whether any of it is actually necessary from a data standpoint. There's some meta-analyses that I had from the previous episode that talks about this. And
they're really not. I've listened to that and ERCast, I think it did. I think it did on them too. But
Rebel did Rebel EM did a really good one.
There's no need for it. There's really no need for it because really it's really, and you know, if you want to go even farther back, it's not even really need to do a rectal exam and look at blood. Blood is blood. If they have bleeding and they're unstable, they need to get admitted to the hospital. It's either ICU or floor. They're going to get a scope, and if they're really sick, they need blood. You can get Protonics drip. If they don't have bleeding, they literally could be followed up by GI the next day after their labs are stable. I mean, we could really simplify that whole process. Unfortunately,
we're not going to do
it depends where you work.
And everyone gets very emotional about these meds, and I think we just got to the point to where my attending wants it, or my attending taught me back when I was in residency.
Yeah, exactly.
This is why I do it.
What we have to do it.
But when you look at the data, especially big meta-analyses that we have now, it's like, why am I, for one, forcing my team to deal with all this? Because depending on your provider, they're just checking a box and ordering it. And the nursing staff is like, oh, I'm just gonna just check this off. What happens sometimes is this: you order it, the drug gets down there, it's scanned, it's on a pole and goes up the patient. Because we have to fix numbers and we have to make sure our scan rates and things are done. I'm not saying people do that, but I just know that you can't find that in the data. So
no, you can't.
Yeah,
it's really the data says it's probably not. Yeah. It's probably a waste of. My thing is, it's probably a waste of time, energy, and money. Yeah. And in medicine, time and money are things you can't get back. Yeah. So don't waste them. Yeah. You can't. Your time you never get back. You're gonna waste 20 minutes mixing a drug. You just wasted 20 minutes of your day. Yeah. And you could be doing something else.
It's so much stuff. But the last one I would talk about is like the whole deal of like IV antibiotics versus oral. Particularly for people that are not sick. So I'm not talking about
we went to push IV meds or antibiotics. Excuse me.
not your septic patients going to the unit. No, I'm talking about the person that comes in with some cellulitis, who they say, I want a one-time dose of Vanc, and your patient's sitting there waiting 2-3 hours just to get the infusion. Not to add to the fact that those big doses usually come from pharmacy.
Correct.
So add 30 minutes to an hour and a half to when you actually find it and start it. So we're talking about 5 to 7 hours for something that makes zero sense.
Oh, absolutely.
Like, it happens so often. You say, oh, just give a one-time dose of antibiotics, or for a simple infection, we have to give IV. Like, I have a simple UTI. We don't need to give, ceftriaxone up front. But it's just,
all of them can give an IV almost. Yeah. I think other than Vanc.
Yeah.
And Gen. Yeah. That's it.
And like, well, the most part is like you don't need.
That's big ones in the ER. Other than if you're doing like an American or some special antibiotic.
But those are sick people.
Those are some people that should be in the ER anyways.
Yeah, but UTIs and sitting in triage. Oh, let's just get them in. They was tachycardic to the 1-teens, nothing else, because they're nervous and they're in pain. And then we just do certain things that make zero sense. There's data out there that says that you should not do this. From a bank standpoint, you don't reach that level AUC to MIC to actually even be beneficial, you're inducing resistance because you have such a low level because you're not following up with multiple doses.
No,
it makes no sense.
Yeah, and that makes the biggest point. I mean, we're giving so many antibiotics. We give so many antibiotics in the ER, so many. I think it's like, one, we got to have a better way to do it. Do they really need it IV? We can do so many PO, we can do so many IV push that have the same results.
Yeah.
And the other things, do they really even need it? Because are we just creating more problems?
Yeah.
And our patients are already complex. And in young people, are we just creating more problems?
And I think fixing this problem helps out a good bit because you fix the IV versus IV pushing PO standpoint. Then you start thinking to yourself from a process standpoint, and then you ask yourself like, wait, does this patient actually need vancomycin, or they just need like ceftonir?
Yeah.
Or they just need something, very simple, and we get so caught up with that.
And what's the difference even in cost?
Yeah.
Just for one PO man versus like two rather big IV medications that we have to give, and it's tying up time. The patient's sitting there for 3 hours getting their dose.
Resources,
resources, time, money, everything.
It makes very little sense, but we just do it because I like the way vancomycin sounds. I like the way just a one-time dose of vanc sounds. So.
Well, and it also goes back to the sepsis guidelines, and since so many people have not done well with it, it's almost like now that like we're forced into. Yeah. Since half the people don't behave, or you didn't behave in the past, you didn't have your numbers right, we're going to make you do everything, when really we could be documenting appropriately and probably getting away from a lot of that.
Yeah, and from the sepsis, that's going to be a whole different topic that we'll talk about, because that's just, I'm happy ASEP came out with some stuff. I'm happy people resisted the push for every year. It's like 3 hours, everything within 1 hour. Pretty sure I'm like, all right, everything happened within 30 minutes. And then I went back and looked at some of the data.
Lower.
And I'm like, statistical gymnastics. I love that word because we do a lot of that where we say, based off this, multivariate analysis, this time window where we saw increasing death versus that, when that wasn't the actual thing they studied. But I digress.
We could go down the sepsis like roller coaster.
But really, the one thing that I'm like super interested in, because with me working where we work now and my past where I work, I see a lot of trauma. I see a lot of patients coming in that need blood. And one of the things that we need to do better is with how we do MTP.
Correct.
It's so much. You can just elaborate on that.
So I think it all goes back to, we have a 20-year, 25-year war still going on. We're with the war in Afghanistan, the war in Iraq, and even Syria, and there's so much data now from the military. And yes, there is a caveat there. These are young, healthy men and women. Yes, they are all type and crossed ahead of time. Yes, they can go next to their buddy, do a rapid HIV, hepatitis, know that they don't have that and can get whole blood. But let's be honest, we know now that all that time that the military studied with their trauma and combat casualty care, that IV fluids are not needed. There's doesn't matter, LR, and none of it works. And it's real simple. You need to give 3 liters just to keep one inside the body. It doesn't carry oxygen. It doesn't do anything. It's not even good for volume expansion. It really doesn't do anything.
And it makes things worse. Coagulopathy.
Absolutely.
That's my big thing. Is like,
and that's a triad.
You're
diluting it, and it's cold half the time. So now you got coagulopathy, you got hypothermia. You're just running yourself into trouble.
Yeah.
And the biggest thing is we also know that permissive hypotension is a big thing. We don't need to fill everybody up with like 8 liters of fluid
just to get their I want their blood pressure to this. It's like resolve your again everywhere. Posted on paper, all the studies say it, but we see a blood pressure that's like 90, SBP at 98, we freak out. It's like, depending on what you're looking at, anywhere from 90, SBP at 90 to like 110 is where you can get them. They don't need to be, map of 80 and stuff like that. They don't need that. Like,
no, and that only goes to like, you gotta remember, it's all about controlling the bleeding.
Yeah.
So it's all about, in trauma, it's all about controlling hemorrhage. We know hemorrhage kills, so it's controlling hemorrhage, whether it's in the field or in the ER. And in the ER, you have to remember, trauma is a surgical emergency, not a medical emergency all the time, which means it needs a surgical intervention. So a patient coming in pale, diaphoretic with 2 puncture wounds in their belly and are tachycardic doesn't need to be in the ER. It is damage control. They're going to be hypotensive, start the blood and move. And I think that's what we get tied up on. We get tied up on these numbers. And the biggest thing is you can in certain scenarios. The biggest thing is blood first. If they need it, they need blood. That's what they need to get. We have the option for whole blood. There are some places that only do whole blood. It is expensive, but to me, it's awesome. You give whole blood, you don't have to worry about the pieces and parts. And then the other part to that is no fluids, but you got to give the pieces and parts. That means you got to pay attention if you're doing bedside. How much blood, how much plasma, how much platelets are you giving these patients?
Communicate.
Communicate.
Because it may be one nurse that's actually doing the documentation who's responsible for the patient, and it may be another nurse actually at the bedside running these things, and depending on your experience level with trauma, it makes it challenging. Pharmacists, this is the area where you can get involved. I'm consistently doing blood because to me, I don't see the difference between running blood and running fluid because I spike something, I put it in a rapid infuser,
and you're giving it. We're giving it. You're getting in our shop, in most all trauma centers, you're giving just blood. You're just going to either put it in 500 bags and you're pressurizing it, or you're putting it through whatever rapid infuser you're using at your facility. You're going to be doing that. And you're going to the OR immediately.
And like, don't play around. Like, my thing is this: don't play around with some of these other things. Like, we shouldn't be talking about pressors up front. Within the first 20, I think the goal now, we shouldn't be thinking about pressors up front unless we've done MTP and like actually got all the products in. Not like I had a case where I got called to the OR for a patient that was like coding in there. They had just gave like just PRBCs, just you know, rep
one,
just solely. They gave
we
that.
give 20 to 30 sometimes.
But then I came in and was like, oh, we've done 4 or 5 of those. No platelets, no FFP.
And I think people forget about that.
And just wondering like why the patient's blood is just like Kool-Aid. And like give factors, give
you
the
gotta
other
give all
components
that
to that.
stuff.
And that's why I love whole blood. But I think pharmacists, this is the area where you can get involved because I've done it when I was where I am now. I've done it at the second busiest trauma center in the world. And if you can take over that, depending on your staffing, if you have one nurse in a trauma bag, and you got 3 patients.
We've had busy days, and it's just you doing all the blood, all the bedside stuff, and one person documenting.
So that's where you need to be able to say, okay, oh, this is why IV access is important. This is why understanding that I don't need a protonic strip that's incompatible with my blood. That's more important. And I don't need to be given 3 liters of cold fluid so a patient comes in and get MTP. So I think communication, getting this stuff done, getting good access, because you'd be surprised what a good 18 can do for you in those situations. Or I really just like a Cordis. I'm not gonna lie. I would love it.
Central access is imperative, but we've had times where we weren't able to get central access, and I got the ultrasound out, and I'm putting 16s in with ultrasound. But if the patient needs to go to the OR, doing time to do the centralized, it's faster just throw an ultrasound line in, start blood and move, or is it faster just to go?
Just go directly there, because there's been times where it's like, okay, get out the way.
It's damage control surgery, which means it's surgical emergency. It needs to be controlled in the operating room.
And I think we just gotta always shift gears when it comes to trauma, because it's so many times where you get a traumatic arrest or you get a really sick trauma patient, and we think, oh, the lactate is elevated, sepsis. What the hell is going on? He got hit by a bus.
I don't like lactate, and that's why lactates are bad.
Like getting
people caught up in these hamster wheels.
It just makes you want to do things that's not important. So like you're saying, blood. From a pharmacist standpoint, if you're not giving whole blood and you're giving like 2 PRBCs, calcium, calcium. Like there are some studies out there using 3 grams of calcium chloride.
Correct. For every one. Well, there was that new paper. I don't remember, it was on and I can't remember who wrote it, but their guidelines are for every unit of blood, give 1 gram of calcium chloride or 3 of calcium gluconate, which is like 10 mLs where we at, or 10 mLs. So it's 3 10 mL vials.
And knowing that, like,
or you can, the fast, and we had the injector.
So if we have like the central access, which is cool, again, depending on your shop and depending on the patient. I'm not going to say what we do or what happens, depending on your institution of how you administer calcium. You have to be very diligent, because usually you have 1 or 2 good access, and I'm not going to like mess up giving blood, but I actually need to give the calcium to help the clotting factors work, because it's a cofactor in like 13 different phases within the clotting cascade.
Absolutely.
So my thought is this: when you first roll in and the blood is getting pulled up, in my head, I'm already asking, can I give calcium? Can I get that in immediately?
It should. I think it should be an
TXA. We're in a different phase of TXA right
Depends
now.
who you talk to and our trauma attendings.
Yeah. We're in a
Some
different
are
phase
like,
of that.
don't you dare do that, and some are like, yeah, whatever.
Yeah. So my thing is like, get that up front. And if you got 216s, get the blood rolling on one side,
Correct.
get your meds in. And there's controversy whether TXA can be pushed or not. I've reached out to your manufacturers and asked them where this hypotension came from in sick trauma patients.
All right,
whether it was the
hypotensive.
drug
So
versus
how
that.
do you tell if it was the drug or just something else?
So I definitely want to get more data on that. If you guys got it, please. I know of a place that's had over hundreds and hundreds of TXA IV push without
Correct.
any effect. Now, I've got some MUEs to prove that, but I think that's from a drug standpoint, get those things in, but don't mess up the blood.
No.
And get those patients out of the ER.
Correct. There's only two caveats, and the one is when you're dealing with head trauma too.
Yeah.
And you do have to be wary of that, where you want your maps. And that's where things get, that's where we're not just talking about just someone bleeding out, whether to GSW to chest or abdomen, or they've got a partial amputation where they're hemorrhaging from a large vessel. You do have to be worried when you're dealing with multi-system, when you're dealing with head injuries, where you want your map, how you're going to do things. And that's where like blood pressures might become, that's where your little caveat is. And then the other thing is, and this is, we've gotten caught on this, if you're giving blood and you're still hypotensive, don't always forget about some kind of neurological spinal shock. Because you can have that, but my thing is, if you think you even have a spinal cord injury where you're dealing with like total neurogenic shock, you still have to assume the patient's bleeding.
Yeah, and volume is volume. You can get that volume in, and it's going to help out, and it helps you identify that quicker. Versus like, oh, I got to give 3 liters.
Of blood. Wait, hold on.
Like, how long is it going to take you to get 3 liters of fluids in compared to just 1 unit of blood? Especially if you guys have access to whole blood. I think it's the cool thing to do now, so people have it more often, even if you have to like reach out for it. But can you talk about like, as far as like activating MTP like prior to a patient get there? Because that's an issue that comes up sometimes where you want the cooler. If you don't have a cooler in your ER that has those things, if you want an extra amount, what's the logistics of getting a cooler to you very quickly?
So that's going to depend on where you work. So one, if you don't work in a place where you don't have blood, this is where you're going to have to use fluids, and then you're either going to have to use push dose epi, or you're going to have to use a pressor along with it. So you're going to have to give 250 mLs at a time, and maybe some pressors just to keep their blood pressure up. If you're in a system like we are, it's real simple. You just make a phone call. It's almost like phoning a friend. So MTP in our, if it's a level A and they're hypotensive and I think their ABC score already sounds bad, I just call. I'll just make the dough, create, or however you guys, it depends how your system's set up. For us, it's create a dough, get an MRN, male or female is what you need to know, and you call blood bank, and you get it rolling is what I always do. You can always cancel it because those packets are usually older blood that's kept off to the side just for that. A lot of times it's just you need to get someone to go get those packets. Because in our system, you could run through that bedside blood refrigerator in 5 minutes. Like not even 5 minutes. You can do it really quick. Especially if you had back-to-back
The case
backs.
I ran through 2 of whole blood up front, and they had like some fluids going on before, so I was like, okay, we have to account for baby coagulopathy from that standpoint. They were still hypotensive, and then we didn't call MTP, so they was like, well, I want FFP now, I want platelets now.
My thing is just call it. And my always thing is like you can always return the blood, and you need to make sure wherever your system is, where you work. The biggest thing is make sure that blood gets back, because you don't want to waste that blood, because then it goes back on them, because they have criteria they have to follow. Then the lab has to, document stuff, and they get in trouble. My thing is, if you think it's bad and you think you're gonna need a lot of blood, I'd rather have it than have to call it and then have someone run upstairs, because it's delaying time.
And I hate, again, I've been fortunate to have enough trauma experience now where I hate when I have a young patient that's dying in front of me and we don't have the tools necessary, because it was a delay here. I had, teenagers in front of me that needed blood, and there was a delay because somebody didn't make a call, or we didn't actually activate it, and there was a miscommunication, or somebody was rude to the blood bank. Don't be rude to the blood bank. Just don't do that.
We had this a month or 2 ago, and I remember at Braid shift change at 7. We ran 2 MTPs right at the same time. And the one was going to the OR anyways, but we had it already started. And it was all right, so what? The patient's going to the OR. That, you know what? At least the blood's getting to the patient. They're gonna have, when they get to the OR, they're gonna have blood ready to go. And that's the thing, is you're not delaying that, because even though the patient's gonna get opened up and they're gonna go in and try to find all the bleeding, they're still gonna need to replace it, and you need to have that kind of supply. It's almost like a supply chain. You got to have that supply chain started, because it is such a resource intense procedure, because blood bank has to get all the blood. They have to get the blood to you. Where are you at? Are you in the OR? Are you in the ER? You know, where are you at with your resuscitation? And it is a major supply and major logistics.
Yeah, and then my thing is, like,
the blood bank
it seems like it's easier.
Of the hospital.
Yeah. It seems like it's easier to like get blood and stuff going if TB like continued in the OR compared to initiating it there. So we start in the ER, and maybe an easier process once they get to the OR, just to have more blood coming up there. Depends on what shop
absolutely, because you're going to have anesthesia,
Yeah.
running all the lines, running all the pressors, running the intubation,
Yeah.
and then they're usually, you know, I'm assuming there's going to be a few of them at bedside attending plus a resident, so someone can do all that, and an OR nurse while they're doing the operating. You know, and they do a little things, set up things a little differently. It would be nice if we did it in the ER, just to make things accessible. But yeah, if there's it's resource intense. MTP is a resource intense procedure. If you don't have like someone dedicated just to run on the blood, you can. I mean, that could tie you up all day, like for an hour easily. On a patient.
Is there anything else? Because MTP, you can really start going deep into every component of it.
Very much.
Components versus whole. How you do your components. 1-1-1.
Should you use TAG along with it?
Yeah, TAG is a whole.
And ROTAM, is that a valuable tool to use
and if,
with it?
Do you have it? How long does it take? Because personally, all level A's, I think we can send one, and like once you get the LY30, that can help you out if you're resuscitating downstairs. Do you use TXA? What products do you use? I'm a fan of it. You know, my buddy Brian Gilbert and all those people who are out there who are like tech specialists. I envy your knowledge when it comes to
I know in the ER we don't. I know there's been talk about some places they wanted to actually even get some of the labs in the helicopter and run TAG as soon as they walked in the door, or even run TAG right then and there in the ER or ROTAM or whatever equipment they're using. And the biggest thing for us, I know, and I'm sure most places, is cost. 2, what's the research and data about it? And 3, if you talk to any trauma surgeon, all of them have just varying degrees of what they prefer to do with their patients. To me, it seems like it makes total sense, because truly, the problem is you have to believe the fact that in the war on terrorism, if truly one comes from, I got 1 unit of whole blood, that means each piece is equal to the whole. And that's, I think, where it gets complicated, because there's really 1 unit of whole blood. Is it really equal to 1 unit of PRBCs, 1 unit of platelets, 1 unit of FFP? Or what's our differences there, and how does that affect? And then the other thing, the bigger thing is, even with MTP with us, is our patients aren't always young, and they have other comorbidities, and what's really going to help them.
For them, especially you got these people who come in that have multiple comorbidities, they got hit, so they got trauma, they're on blood thinners, they're not, they're baseline hypocalcemic.
Oh, heaven forbid they have an LVAD.
oh God, I don't even want to go there.
So, and that's where I think where it's all in all, the military data is great. I've read the articles. It's really good. I think taking that and converting to what we do when it's young, healthy people, that's easy. You know, if you're male or female, you just, what are you going to use? And the pieces and parts probably are going to work for them. The caveat becomes is when you have other things going on. Comorbidities, pregnancy, complications. I think that's where it gets hard in MTP to start transferring what's going to work, what's not going to work. And the other thing is whole blood's expensive. It would be nice in our world if we can get it, and it's only AB. Has to be AB blood, and it has to have very low antibodies, and it's only like 10% of the population. It's hard to get totally need to be.
But it is phenomenal. Like
it's easy.
Anecdotally, it's like you give a couple units of whole blood, your patient's sick, it's like they pep up, and they're starting to fight you in the vent now a little bit because they got that great perfusion, and it's okay. Now we're ready for OR, and they go and they just like have a beautiful recovery. Again, I'm just a pharmacist, but
for me, it would be nice to be able to just replicate what they did in the military and do it in the civilian world. I just think it's going to be hard. So you're still going to have to understand the pieces and parts and not forget them. And that's where we get confused, because even I'll get like, oh yeah, we give like 8 units of PRBCs, but where are the platelets and the FFP? We didn't do that. And you can't mix them, and some of them can only, so you might need like 3 different lines and 3 different, you're given 3 different products. And
make sure your line's not getting kinked, your blood pressure cuffs not going off and stopping the blood. Like,
so
we need blood pressure, but like, don't let it stop the blood, because it's just little caveats.
There's little caveats that get caught up in, and that's where things get difficult.
Yeah. But that's all I had. I think we're getting to a nice stopping point. Guys, let us know how you enjoyed this concept, with this being more of a video format. I thank Brian for letting me come to his shop.
I know, we're in the brewery actually.
Yeah, we may have a little bit more events here in the future if he allows us, and I wouldn't mind having people come here, have a nice drink,
there you go,
and just enjoy themselves. So guys, check the show notes out. I'll put more of that on the website. How can they find products for you? Where?
So we're on. We do most everything is in-house. So it's Oak Grove Brewery in Somerville, South Carolina. Most everything is in-house. We do all lagers. We're German-centric, so we do have lots of lagers on tap. I do different. I'm the head brewer and the owner, so I do different variations of all the lagers. So we do light, dark. We do specialty lagers. We also do Berliner Weiss. We got 2 Berliner Weisses on tap right now. We have a peach one and a mojito one. We do an IPL, or which are imperial, an IPA that's a lager, basically, to do it the best way for all the hop heads out there. But we do a lot of traditional German stuff. So we have Jagenboard, which is our Munich Helles. We do a Ausfahrt, which are German pills. We have Triple H, which is our German Hefeweizen. That's our bases. And then we also do a Munich Dunkel, and then we have a Schwarz beer we're going to be doing. We're actually taking our Schwarz beer and putting it on all the time, and we're going to try some different things with that. And then we have, my wife runs a Women in Brewing, so we do a Women in Brewing. They do a beer every quarter. We have one of theirs usually on tap. So we do a ton of specialty beers, especially in May. So we do Star Wars, and we did a bunch of Cinco de Mayo beers too.
So you guys will probably see more from Brian. You'll see more from his shop. We're gonna try to do as much as we can here. This is phenomenal. So again, I always end it out the same way, guys. You don't have to be a pharmacist. You don't have to work in the ER, but everything you do, make sure you farm so hard.